ladies and gentlemen. Improving safety and quality in the cath lab is becoming quite an important topic to which we don't always pay adequate amount of attention. My disclosures. Obviously, there are several areas where we want to focus on when looking at safety and quality, and one is most important of all, and that is ensuring the patient's safety and prevention of mishaps or complications or accidents, prevention of complications as well as failures of procedures, and then eventually how do we improve quality? Well, we want to assess the results and improve our own practice. This is a checklist, WHO checklist for surgical safety, and I'll break it down into small portions. And one, this is widely applied in theaters nowadays by surgeons, but it's an area where we in the catheter lab would need to use perhaps a lot more than we have done in the past. And that is, on the right-hand side, I've summarized the checklist on the left, which is before anesthesia or before sedation, you check that the patient is the correct one. You check that the procedure that is planned is the correct one. There is a consent form that has been agreed and signed by the patient, that the anesthetist as well as the other medical staff have reviewed the patient history. Pre-procedure assessment has been performed by the medical team. The pre-procedure anesthesia assessment as well as the safety check has been performed by the anesthetist. And then you've agreed for interventions, for example, on the use of anticoagulants. Within the catheter lab, and on the left it's more before incision in the theater, there is a period of timeout where all the teams members introduce themselves as well as their roles. So everybody is clear who in the catheter lab, who the members of staff are and what they're going to do. And that includes, of course, cardiologists, anesthetists, and the nurse. They also have to confirm that the patient is the correct one and that the procedure that is planned is discussed. The cardiologist who's going to be performing the intervention, and on the left it's obviously the surgeon, discusses all possible critical or events or complications that may be likely to occur during the procedure and how they will be addressed and how they will be dealt with. And then at the end, before leaving the catheter lab, and on the left it's more before leaving the theater, the nurse has confirmed the procedure with the team, check any instruments or equipment that has been used, and it's all accounted for. And there may be some complications that have to be addressed after the procedure in the recovery or on the ward or in the intensive care unit, that those key concerns have been communicated with the next team that takes over. And on the left, that is obviously the surgical team communicating with the recovery or intensive care unit. So that is a underemphasized safety checklist. Now, after that, for interventions, it's important for us to be very self-critical because before you bring the patient in, you need to plan everything. It is important for the medical team to plan, and that is planning all of the stages. It's not just, this patient is going to have an ASD. It's to plan all the equipment being available in the catheter lab so that you don't halfway through a procedure ask for some piece of equipment and it is not available. And therefore, as a major or as a general rigid rule, no patient should have a procedure attempted. No patient should be brought into the catheter lab and have the procedure attempted and then abandoned because some piece of equipment, absolutely crucial, is not available. A size of the device, a size of the stent, a size of the balloon is not available. That should not happen. And that is the most important part of ensuring safety for the patient in the catheter lab for interventions. How do we assess quality and outcomes? Well, hospital mortality gives us an indication of the safety within that hospital for a particular procedure. Hospital morbidity gives us the efficacy of that procedure. Long-term results give you information about the quality of care, and the patient satisfaction, if you do patient satisfaction questionnaires, give you information about the reputation. And all of those four factors combine to give you information about the performance of that unit and of that team for any type of procedures, be they surgical or intervention. Now, in order to assess quality, we need to have the ability to compare the results of any treatment that we carry out on congenital heart disease. And in order to assess those results and compare those results, we need to have an agreed nomenclature. Registries will be needed, and then whatever comparisons are made need to be valid and reliable. And these are areas where we still struggle around the world, because the congenital heart disease nomenclature is only just recently, in the last few years, been agreed worldwide. There is information available already on congenital heart surgery. Some limited information is available for cardiac catheterization and interventions. There is a lot of information by the intensive care societies on intensive care data. There is information about anesthesia and perfusion data. The surgeons have been very meticulous over the last decades now in obtaining some of that data. There's a lot of work that has been done by the surgeons. They're way ahead of cardiologists when it comes to assessing results and comparing them. And Europe has been at the forefront. For example, the European Association of Congenital Heart Surgeons Association has been led by people like Bogdan Maruszewski, François Lacour-Gaillet, who have developed the EACTS congenital database. And that has been work going on since early to mid-1990s in Europe. The Society of Thoracic Surgeons have also been developing the congenital heart surgical database in the US for the last 12, 13 years. And the EACTS database, a lot of work has gone into complexity score projects such as the Aristotle, where François Lacour-Gaillet, formerly in France, then USA, and now in London, has really been leading. And this is just one example. I'm not going to go into great details of this, but this is one example of comparing results between hospitals. And this is based on Aristotle basic score. The higher the score, the more complex the congenital heart defect being treated surgically. The lower the score, the less complex. And then on the y-axis is the mortality. And so ideally, you want your hospital with the highest complexity score to be in the lowest mortality area. So you want the hospital to be in that segment. If you have a low complexity score but high mortality, then obviously your unit is not performing so well. And this sort of anonymized plot gives a lot of information about your surgical performance of your surgical unit. The Society of Thoracic Surgeons in the US, initially by Gus Mavroudis and now Jeff Jacobs, have been collecting data of the surgical results in the US. And again, they've accepted the complexity score based on the Aristotle score developed by EACTS. And so, for example, as the Aristotle basic score increases, the mortality increases, but that gives you an indication of, for example, relatively simple surgical results with a mortality of 1.6%. As the Aristotle complexity score increases, the mortality for that population has increased to 9.9%. And you can then put your own unit results within that sort of information and obtain indications or data about your own unit performance. In the UK, we've been doing something similar for surgery based on CCAD, which is now called NICOR, and we've been collecting data for the last 14 years on surgery. For example, on the left here is tetralogy of Fallot funnel plot, and all these dots are different units in the UK. So, for example, if a unit falls below this red line, that means that that unit is not performing so well. And so the CCAD, now NICOR, inform or contact the medical director of that hospital to say for this patient, or for this patient population, the tetralogy of Fallot results in your unit are not as good as the rest of the units. You need to look into it. And how do they look into it? Well, the Surgical Association, Royal College of Surgeons, sends a team to that unit to look at how the results have been achieved, whether there is a difference in the complexity of heart lesions that they're treating, and whether that can be accounted for by the complexity, or whether the team needs to have retraining and further expertise trained. And so here's a similar funnel plot for arterial switch operation, and you see all the units fall above the green line, none of them fall below the red line. We have collected similar data for interventions, but it is a very simple data, because the only thing that has been collected in the UK is the mortality, and we know that mortality is very low, and therefore mortality after interventions is not going to be a very sensitive indicator when it comes to improving your quality. For interventional catheterization, therefore, we have a problem, because we do not have an agreed nomenclature for different procedures. There is no agreed definition of complications or severity classification, and outcomes may be just simple procedure or technology specific, and no adjustment is made for case mix complexity. Because, for example, in order to assess interventions, we need to decide how we decided on a particular intervention. There isn't an agreed, if you pick certain lesions around the world, there isn't an agreed consensus by experts as to whether intervention is the best treatment or whether that particular lesion should have surgical treatment. We have a personal belief of potential benefits, and that then determines how that patient may be treated. Then there is lack of evidence in patient selection and timing of interventions as well, because we do not have large randomized trials for interventions at all in congenital heart disease. Quality controls and measures is, for example, is mortality and morbidity adequate information, or whether we should be looking at other complexity scores and quality of life measures in order to help with judging quality. So in the US, the impact registry has been attempting to collect some data in terms of identifying variability of catheterization procedures and linking that variability to outcomes. This will help to assess performance and provide benchmarks, and hopefully by a combination of all that, it will help to improve quality of care in that particular set of patients. Now, impact registry is not comprehensive. They collect some data on all cases, and those cases include diagnostic catheterization and biopsy, so not just specific interventions. But there is more focused and comprehensive data collection on specific cases. And initially, the data is collected up to hospital discharge, but ultimately the plan is to provide or collect longitudinal data. And the impact registry is open to all participants, but at the moment, because of cost implications, not everybody, even within the US, has joined in, and certainly very few units from outside of US have joined. So, for example, there is a limitation of number of procedures on which impact registry collects data, and this is on diagnostic catheterization, ASD device closure, PDAs, pulmonary valve balloons, aortic valve balloons, coarctation interventions, and pulmonary artery stenting. Only those groups of patients or groups of procedures have had data collected, not all the rest of the things. Now, what about outcome measures in those particular patients? For example, how do you judge quality of care or treatment in a unit? The impact registry collects data on, for example, ASD patients leaving the catheter lab with either zero or trivial shunt, not significant shunt. PDA patients leaving the catheter lab with, again, either zero or trivial shunt. Coarctation patients treated with, whether it's balloon dilation or stent implantation, leaving the catheter lab with gradients less than 10 millimeters of mercury. Pulmonary valve balloons leaving the catheter lab with gradients of less than 30 millimeters of mercury. ASD device embolization, PDA device embolization. major adverse events, transfusion events, and airway events requiring intubation. The major adverse events, again, it's not a comprehensive collection of adverse events. For example, permanent or temporary pacemaker need, cardiac arrest requiring cardiopulmonary resuscitation, tamponade requiring drainage, embolic stroke occurring within less than 72 hours, unplanned cardiac surgery related to the adverse event, not a patient who has intervention followed by surgery as a planned procedure, and of course, death as a major event. So there are problems in terms of the amount of data that is collected and how they are analyzed in the impact registry. There are other groups, for example, MAGIC, or the Mid-Atlantic Group of Interventional Cardiology, who are attempting to obtain data on long-term outcomes of interventions, limiting themselves to 8 procedures. And again, data submission is automated on web-based. And then the other group is CCISC, the Congenital Cardiovascular Interventional Study Consortium, based in Michigan, and this collects data on adult and pediatric cases for congenital heart disease. And in this particular, I'll focus briefly on CCISC, because Dave Nickonen from Florida has been helping with this registry with Tom Forbes. And the aim is to attempt to stratify cardiac catheterization procedures, define incidence of serious adverse events, assess performance between institutions, and then also assess operator performance as well. And so the data that is entered, and our own unit submits data to CCISC, is institutional data, patient data, procedure data, physiological data, risk score is then assigned, outcome complications, access site complications, procedural complications, and then there is a list of miscellaneous complications, and also longitudinal data, for example, post-discharge complications. I'm not going to go through this busy slide, because this summarizes the definition of serious adverse events. For example, any complication causing extended admission, fistulas after access, femoral arteriovenous fistulas requiring surgical or catheter interventions, venous compromise requiring surgical catheter interventions, infections, brachial plexus injury, and things like that. But this is an attempt to try and risk stratify depending on age and requirements after the procedure and other additional systemic illnesses. For example, each of these lesions less than 2.5 kilograms at the time of procedure is assigned a higher score than if the weight is more than 10 kilos, and so on. And so this then helps you categorize the patients into different risk categories. Data has been collected up to 2 years ago in over 11,000 patients. 80% of patients were less than 19 years of age. The serious adverse event incidence was around 7% for children under 1 year of age, and just over 2% for those between 1 and 18 years. And that gives us useful information. For example, here, this is data by institutions, and this highlights complication incidence by institution based on babies weighing less than 2.5 kilograms. And so you can see here that some institutions have no complications in this population, and others anywhere up to 50%. And the next group is those with weighing between 2.5 to 5 kilograms, of course, with slightly more complications. So it really, your own unit, you will be assigned a number, and you can work out which unit yours is in comparison and how it is comparing with other units. And as a result of that data collection, funnel plots have been produced along the lines of what we have in the UK, where this, for example, is occurrence of serious adverse events in all risk scores, and if you're falling outside the upper confidence limits, then obviously you have to reevaluate yourself. The disadvantage of the CCISC is that there isn't an overarching body who contacts the unit saying you're performing less well than you should be. For example, here, this plot shows adverse events in low-risk patients, low-risk population of patients, And here it's a moderate risk, and this is in the high-risk patients, and a couple of units falling outside the confidence limits. Now, funnel plots have a use in that outliers can be identified by the units themselves, but you have to then look at the reason for becoming the outlier, because there may be system differences in practice, and they may require a root cause analysis and reporting in order to work out whether there are major differences in practice between institutions. And so that gives a potential to give feedback to units and identify the best practice to units that may be underperforming. And so similar strategies can be applied to areas such as radiation exposure and procedure duration. The last group is data collection is led by Lisa Bergerson in Boston, and that's called C3PO Registry, which is Congenital Cardiac Catheterization Project on Outcomes. It's funded by American Heart Association. 8 centers have been submitting data, and again, it's an attempt to risk adjust for adverse outcome assessments. It's based on internet web-based data collection. And over 15,000, now the data is much more detailed, 15,000 cases were collected. Only 10% of those data were audited and validated. And again, this is an attempt at risk stratification based on age, weight, lesions, and various procedures. And in that C3PO registry, the serious adverse event ratio comparison again gives you some reasonable information. For example, these are different units, their serious adverse event ratio. So the observed adverse event rate is seen here, expected here, and the nearer you are to 1 or less than 1, the better your unit is performing. So these units that have a ratio of more than 1, 1.3, 1.7, obviously you have to look at the reasons for why that unit has a higher adverse event ratio than expected. And that, again, with the critical analysis, self-analysis, it will help to improve your unit performance. Other areas that we should be looking at are reducing radiation exposure during interventions, not surprisingly reducing adverse events, and improve patient-centered care. Our own unit, this is a simple example of radiation exposure. For example, we compared our data because we made major changes in 2005 to before 2005. The radiation exposure for pulmonary valve balloons was here. After 2005 up to recently, our radiation exposure is considerably reduced, and that has been applied to all areas: coarctation balloons, coarctation stents, PDA occlusions, ASTA occlusions. And that was really just by simple looking at our practice before that era, made a few changes after that era, and how that has resulted in reduction of radiation exposure. And that radiation exposure provides safety not just to the patients but the operators and all the staff in the catheter lab. And again, it's an area that is under-evaluated and under-emphasized in all of the catheter labs around the world. Now, in order to improve safety and quality, we know that mortality after interventions is extremely low, so that is not a good marker. Morbidity gives us some useful information, but not enough. We have problems in the UK with interventional database, data collection. The problem is still that we do not have ability to risk stratify when we analyze the data for interventions. The surgeons are way ahead, and we need to catch up. There are registries in the US that are attempting to address some of this risk stratification. Areas such as length of procedures as well as reduction of radiation will assume much more importance in addition to complications and morbidity that we're beginning to collect. All